Again, this is a new session this year that we're doing quick shots. It is 2 minutes for presentation, 1 question, and now that we actually have the same order that our IT people have, we will be able to move appropriately through the presentations. So, and for the presenters, this is the little handheld device. The green button will forward the slide for you so that there's no confusion when you come up. And with that, we will start. We will cut you off at 2 minutes because it's the only way we are going to get through this entire session in time to get you to the welcome reception at 7. So the first speaker is Dr. Andrea Gongora. Do blinded temporary gastric stimulation trials for gastroparesis improve patient selection for permanent implant?
Good evening, and thank you for the introduction. Gastroparesis remains a misunderstood condition in pediatric patients, causing them to suffer debilitating symptoms that are often refractory to medication. Previously, we have shown that gastric electrical stimulation improves symptoms in children with a high success rate using temporary implantation for patient selection. Despite this, there's still about a 20% failure rate after permanent implantation, requiring explant within 6 months, which is concerning for a placebo effect. We wanted to see if blinding patients during their temporary trial resulted in better patient selection and early failures. We did this by selecting patients who underwent temporary GES over an 8-year period and then cohort stratified them into non-blinded and blinded groups. Their baseline symptoms and responses were measured using Gastroparesis Cardinal Symptom Index. Overall, we had 84 patients undergo temporary gastric stimulation trial with 57 non-blinded and 27 blinded. As you can see in this table, there were no differences in demographics or other variables between the two groups. What we found was that 96% of patients in the non-blinded cohort had improved symptoms during their temporary trial, with 86% receiving a permanent implant. This is compared with the blinded group, where only 52% of patients had improved symptoms during their temporary trial, and 44% received a permanent implant. Of those 44%, there were far fewer early failures requiring explant, but long-term outcomes still need to be further studied. This graph shows that a successful blinded trial was when symptom improvement was concordant with the device being turned on as opposed to off. Therefore, blinding patients during their temporary trial resulted in significantly lower permanent implant rates and thus better patient selection. Thank you.
Thank you. Any questions? Well, I have one question. What would you recommend? What would you do today if a patient shows up and shows symptom relief on a non-blinded stimulation but would not be willing to have a blinded?
So when we did the trial, patients at the time, they happened at different times. The non-blindeds were done from about 2014 to 2018. And then we started doing the blinded trials to see if that improved patient selection. So the idea would be to not do the non-blinded ones.
Great. Thank you very much.
Thank you.
Our next speaker is Dr. Claire Wunker, who will be talking about pediatric surgeons spare more ovaries than their gynecologist counterparts during surgery for ovarian torsion.
Thank you, and thank you for allowing me to present. We have no disclosures. Ovarian torsion accounts for 3% of all pediatric acute abdominal consults. And doing an oophorectomy can alter fertility if it's required. In patients with ovarian torsion, urgent surgical intervention is indicated to preserve ovarian tissue. So our question was, does surgeon specialty matter for ovarian preservation? Our methods for this, we conducted a retrospective review of the American College of Surgeons NITSQuip pediatric database, looking at the years from 2015 to 2020. We used an ICD-10 diagnosis code of ovarian torsion, and with this, we found a total number of patients of 1,707. We then looked at who was operated on by a gynecologist and who was operated on by a pediatric surgeon. What we found was that in this group of patients, there were differences between the two surgical specialties based on age, weight, race, and bleeding comorbidities. Pediatric surgeons operated on younger and lighter patients, and gynecologists tended to have more bleeding comorbidities. What we found was that the oophorectomy rate in pediatric surgeons was 29.2% compared to 40% in gynecology. Additionally, pediatric surgeons had a shorter operative length, and gynecologists had a shorter length of stay. Interestingly, the pediatric surgeons had more lap converted to open cases compared to their gynecologist counterparts. They had similar readmission rates and reoperation rates. Our limitations of this study is that we did not account for secondary diagnosis, the possibility of malignancy in these ovaries, the ovary status on reoperation, and the reason for ovarian torsion. In conclusion, our study demonstrated a decreased rate of oophorectomy in patients operated on by pediatric surgeons, which could lead to improved fertility in these young patients. Thank you.
Question from the audience?
Yeah, it's interesting because actually it was published a while ago, and this is more recent data than the last publication. So I think that there was kind of a flip in that pediatric surgeons are now trying to preserve ovaries. I think it's due to teaching and encouragement to try and for ovarian preservation.
Great. Thank you very much. Oh, it's in a, thank you.
Thank you. Our next presentation is by Dr. Cruz Centeno on long-term recurrence rates and patient satisfaction after repair of pectus excavatum.
Thank you and good evening. Pectus excavatum is the most common congenital chest wall deformity seen in pediatric patients, and it affects approximately 1 in every 1,000 children. Correction is usually performed by minimally invasive bar placement. However, due to the timing of pectus excavatum repair, long-term follow-up for these individuals is uncommon, as many patients graduate to adult providers soon after bar removal. Therefore, our goal was to evaluate the long-term satisfaction in patients who completed bar removal after minimally invasive repair of pectus excavatum. To do this, we identified all patients with pectus excavatum repair and subsequent bar removal at a single pediatric center from January 2000 to December 2020. We performed a retrospective chart review and a telephone survey that evaluated if they had any perceived chest wall deformity recurrence, if they required surgeon reevaluation, and their overall satisfaction after completion of surgical treatment. Our response rate was 26.2%. Most of the respondents were male with a median age at surgical correction of 14.9 years. The median time from bar removal to survey completion was 9.6 years, with respondents having a median age at follow-up of 25 years. 96.7% of the respondents reported being satisfied with the surgical therapy. 30.7% reported a subjective persistent chest wall deformity recurrence, of which 12.8% were seen by the surgeon and 2% required reintervention. Therefore, we concluded that there appears to be a high level of patient satisfaction many years after repair of pectus excavatum and bar removal. The reintervention was also low despite some patients reporting a perceived chest wall deformity recurrence. Thank you for your attention. I'll take any questions.
Hello, Dave Notriga, Phoenix. Any idea if that high number of perceived recurrences, if those could have been incomplete repairs from the beginning? So I think in the early part of the study, I think it was very common to maybe not have as complete a repair as we get in 2023.
Thank you for your question. So since most of the patients that reported a perceived recurrence did not sought surgeon reevaluation, that question is hard to answer. Only 6 of those that mentioned perceiving a recurrence actually had a surgeon reevaluation, of which only 3 require a reintervention. So most of them just said that the perceived recurrence was minimal and they didn't have any symptoms to seek any further intervention.
Great job. Thank you.
Thank you.
Next, I'd like to welcome to the stage Dr. Brittany Levy, who will be speaking about a data-driven methodology to decrease preference card waste, a quality improvement initiative.
Hello, my name is Brittany Levy from the University of Kentucky, and thank you all for allowing us to present our work regarding our data-driven methodology to decrease preference card waste. So as many of you realize, there are tens of thousands of procedures. In order to obtain the desired items in the operating room, procedures are linked to a preference list. These lists are made up of all the disposable and non-disposable items that are needed for an operation. Unfortunately, these lists are frequently added to but infrequently audited. Classically, preference card quality improvement projects have aimed to standardize multiple surgeons to a single preference card. It's usually aimed to equalize cost of operations across multiple surgeons. However, this doesn't standardize how surgeons are actually completing these operations. Therefore, there's frequently drift from the standardized preference card, whereby some surgeons may only use a portion of the items and others may individually call for other items. Therefore, a different approach would be to use a data-driven, utilization-based method to identify what the surgeon is actually using and create the preference card based on historical use with an aim to reduce return rates and instrument waste. Therefore, we aim to create a utilization-based preference card, which was surgeon-specific with key stakeholders from the entire surgical team. To do this, we started with one operation by one surgeon. We used 32 laparoscopic appendectomies by a single surgeon at our tertiary pediatric care center. It performed a utilization-based review and compared efficiency, cost, and outcomes to 24 lap appendectomies post-intervention. The intervention was a utilization-based review, which included looking at every item on the preference list and identifying the frequency in which they were used. In cases where the items were used less than 40% of the time, we reviewed these items with a multidisciplinary team. Together, we determined which items could be safely removed. We then looked before and after at efficiency and cost metrics, including return rate and savings. Return rates dropped from 33% to 25% significantly, and while the cost of the operation did not significantly decrease, the variability of the cost did decrease as seen in this box plot. Overall, utilization-based preference cards improve efficiency and reduce costs to improve overall healthcare utilization and surgical procedures. Thank you. I'm glad to take any questions.
How did you get all of the nurses to participate in this QI project? Because getting standardization and our preference cards updated seems to be a very hard barrier to overcome.
So it's interesting. We had originally had a QI project in our adult surgery where they had tried to standardize the card, and we went to go look at lap chole and said, oh, we already fixed lap chole. But then you ask the in-room staff, and they say, yeah, you fixed it, but this surgeon likes a 10-millimeter port, and this surgeon likes this, and instead we're actually running around. It's chaos in the morning trying to get what the surgeon wants because it's not on the preference card. So we were like, well, let's make your day better and easier, and that got a lot of buy-in to be like, oh, I don't want to, be frustrated in the morning trying to get what these people need when it's not on their card. So that was actually a very successful approach, and we had a lot of nursing buy-in, and we continue to have nurses and scrub techs asking if we can approach next services.
Great work.
Great, thank you very much. The next presentation is by Dr. Alicia Greeneck on implementing an MRI protocol for the evaluation of pediatric post-appendectomy abscess, a quality improvement project.
Thank you. CT scans are often used when cross-axial imaging is required for the evaluation of post-appendectomy abscess. MRI has been used with success for the diagnosis of pediatric appendicitis, but few studies have utilized MRI in the post-appendectomy population. We designed and implemented a QI project in 2018 where a comprehensive MRI protocol was implemented to replace CT scans in children with suspected post-appendectomy abscesses. Our goal was to decrease the use of CT scan by 50% in 12 months and sustain those results for 1 year. Our cohort consisted of 68 patients. In the pre-protocol period, 100% of patients had a CT scan performed. Post-protocol, the use of CT was 31.7% overall. 81% of patients had abscesses identified. There was no difference in the proportion of abscesses missed by either modality. There was also no difference in drainage procedures performed, drainage procedure type, which was majority CT guided at our institution, or return to the ED, OR, or readmission. This P-chart demonstrates the decreased proportion of CT scans to cross-axial studies performed, which correlated with the timing of protocol implementation. The majority of protocol deviations were within the first year, which were mainly secondary to provider unfamiliarity with the protocol. While we did not achieve our initial aim of 50% reduction in CT scan use in 1 year post-implementation, tracking our protocol compliance and targeted re-education efforts facilitated achieving our aim in year 2 post-implementation and sustaining that success. To conclude, the implementation of a post-appendectomy abscess MRI protocol decreased CT utilization in the pediatric population with similar diagnostic and clinical outcomes. Thank you, and I'd be happy to take any questions.
Robert Collins from Yale. I'm wondering about your protocol, whether it uses ultrasound to start with, because we often find these with ultrasound, and then the interventional radiologist gets to tell us whether they need a CT scan or not to be able to train it. Thank you.
Thank you for your question. So our protocol does not have ultrasound specifically in the protocol. That is why the protocol was actually formed at our institution. So at this time, around 2018, we had a shortage of ultrasound sonographers at our institution. We were having to wait a full weekend for ultrasounds to be performed in some cases. So we did make this protocol on the basis that a ultrasound could be performed by the surgeon by preference. And if cross-axial imaging was indicated, that's when the protocol came into play, and that's when the MRI was ordered instead of a CT scan. Thank you for that question.
Great job. Thank you.
Thank you.
Next, we'll be hearing from Dr. Michelle Coughlin, who will speak on factors affecting extended length of stay in the pediatric patient.
Thank you, American Pediatric Surgical Association, for this opportunity. Many factors have been associated with longer hospital stays, but not if these factors lead patients to exceed their predicted length of stay. The Center for Medicare and Medicare Services predicts hospital length of stay based off diagnostic-related group codes, which are not specific to pediatric patients. The purpose of our study is to identify and understand all factors affecting length of stay in the pediatric patient and address them to reduce length of stay. Also to evaluate current DRG codes and length of stay predictions in pediatric patients. We conducted a retrospective chart review of admissions that exceeded CMS length of stay predictions at Children's Hospital of Michigan from 2018 to 2020. 6,985 admissions were included from 5,123 patients, resulting in over 53,000 exceeded hospital days, with an average length of stay of 12.4 days. 500 of 999 possible DRG codes were represented. Admissions were compared between surgical and medical, with additional surgical subgroup comparisons between admissions exceeding and not exceeding length of stay. Surgical and medical admissions differed. Surgical admissions accounted for more exceeded hospital days and were more likely to be associated with congenital malformations. Surgical subgroups were divided by primary operative specialty. Pediatric surgery had the most admissions, while cardiovascular had the most exceeded days per admission. Surgical subanalysis identified specific factors affecting length of stay and DRG coding by comparing the exceeded length of stay admissions to non-exceeded. Factors included factors related to patient presentation, treatment, discharge planning, and coding, and differed between subgroups. Medical admissions accounted for 61% of admissions exceeding length of stay and were more likely to be associated with chronic medical conditions. 26% of admissions exceeded length of stay in this study period. From our sub-analysis, we concluded that specific subgroup-related factors can be addressed to reduce length of stay. These factors fell into 3 categories: clinically related factors, errors in hospital billing coding, and a need for pediatric-specific DRG codes.
I had a question. Have you looked into any software-based or kind of electronically automated solutions to potentially fix the coding issues that you identified going forward?
So we did specifically at our institution look at, so when we write notes, we put ICD-10 codes in, which then go to the billers for inpatient billing. Our hospital system, that is outsourced. So these billers are trying to convert ICD-10 codes to these DRG codes, which are less specific. So we're working on education for these inpatient hospital billers. That's something we're working on.
Great job.
Thank you.
Our next presenter will be Dr. Carlos Huerta on uncovering risk factors and outcomes of pulmonary embolism in a nationwide cohort of hospitalized children.
Thank you for the opportunity to present today. The incidence of pulmonary embolism, along with VTE complications, has increased in recent years in hospitalized children by up to 15%, and mortality in this population is significant, with approaching nearly 10% of hospitalized pediatric patients with pulmonary embolism. Yet few pediatric-specific studies have been undertaken to ascertain specific risk factors for these children. Therefore, the objective of our study was to characterize risk factors and outcomes associated with PE utilizing a nationally representative cohort. We queried the nationwide readmissions database from 2016 to 2018 for all children less than 18 years old with a diagnosis of pulmonary embolism and excluded those with a diagnosis of septic PE. Regarding index hospitalization outcomes, we identified a cohort of 3,440 patients, of whom the majority, 77%, were aged 13 years and older, and there was a predominance of females at 57%. Regarding concomitant diagnoses, hematologic and solid tumor malignancies represented only 11% of this cohort, and patients with hypercoagulable disorders accounted for 5% of these patients. Furthermore, during index admission, surgical procedures were performed in 9% of the overall cohort, and central venous catheters were placed in 19%. Overall inpatient mortality was 5% of our overall cohort. However, by looking at prior hospitalizations within the previous year of their index admission, a significant number, 736, or 21% of our overall cohort, had a prior admission, with 17% of this group occurring at a hospital different than their index admission. Furthermore, central venous catheters were placed during a prior admission at 21% of this patient group. To examine multiple factors that could contribute towards inpatient mortality after PE, we performed a multivariate analysis examining multiple factors and found that prior admission to a different hospital, as well as some index surgical procedures, including neurocranial and cardiothoracic subtypes, as well as central venous catheter placement, were associated with higher odds of inpatient mortality. Ultimately, hospitalized children with pulmonary embolism have a significant rate of prior hospitalizations within the same year, and a number of these patients, 17%, occur at a hospital different than their index admission, highlighting the need for stringent chart review and evaluation of these patients upon initial evaluation. Furthermore, there was a high frequency of central venous catheter placement, and some inpatient operations, such as neurocranial and cardiothoracic subtypes, may be associated with a higher odds of mortality, although this may also represent the acuity of these surgical populations requiring these operations. I'd like to thank all my co-authors and be happy to take any questions.
Great job. I think in the interest of time, we're going to have to go to the next presentation, but excellent job. Our next presenter will be Dr. R. Scott Eldridge on the topic of pectus excavatum and its cardiopulmonary effects in the pediatric population.
Thank you. I have no disclosures. We sought to determine if Haller index and correction index were predictive of cardiopulmonary performance in children during exercise. We performed a retrospective review of patients of age 21 and younger with pectus excavatum who had preoperative exercise stress testing. A total of 537 patients were evaluated with a median Haller index of 4.7 and correction index of 33%. Notably, 26% of our patients had an abnormal and very low BMI of the 10th percentile or less. On linear regression, we found poor correlation between Haller index and peak VO2 with an R-squared of 0.001. We similarly found poor correlation between Haller index and predicted O2 pulse, seen in the left lower graph. On the right, you can see that correction index also correlated poorly with both peak VO2 and O2 pulse. We subsequently divided our patients into quartiles by Haller severity. The patients with the more severe Haller index quartile were more likely to have an abnormal VO2. We further stratified the quartiles into by a very low BMI of the 10th percentile or less. Patients with a very low BMI were more likely, seen in gray, were more likely to have an abnormal VO2, irrespective and independent of their quartile. This quartile relationship held true, seen in blue, between Haller index quartile and O2 pulse in the left lower graph, and correction index quartile and abnormal peak VO2 in the right graph. Finally, we found that very low BMI, seen in gray, was a strong predictor of poor performance with a VO2 and O2 pulse when stratified by severity quartile. Thank you.
Hi, Andre Heber from Florida. Great presentation. This data I think your group already presented part of it at different meetings, very meaningful. Can you tell us how you plan to utilize that? I presume some application for getting approval for surgery for some of these patients?
Yes, as part of the clearance for surgery at our institute, we do a few things. The first is get an echocardiogram, but then also have our patients undergo these stress exercise testing. One of the questions we had was, what is the utility of this testing, and is it correlated with our patients with severity? One of the conclusions that we drew from this is that it doesn't necessarily correlate with their severity of their pectus severity by Haller index and correction index, and that other things may contribute to that, like a patient with the very low BMI. So going forward in application of this, if a patient has a supernormal or a supernormal cardiopulmonary performance, like a very high VO2 max, that doesn't necessarily mean that their pectus isn't affecting them in a certain way. So I think just this test alone isn't predictive enough to say whether a patient should have their pectus repaired.
Thank you very much.
Our next presentation is on vascular trauma in children, etiology, management, and outcomes of patients at a level 1 trauma center, presented by Derek Williams.
Thank you for allowing us to present today. Though rare, pediatric vascular trauma can lead to significant morbidity, including loss of life and limb. The purpose of our study was to evaluate the etiology, management, and outcomes of pediatric vascular injuries managed at a level 1 pediatric trauma center. We performed a retrospective review of children less than 16 years old who underwent surgical repair of vascular injuries over a 10-year period at Children's Memorial Hermann Hospital. We collected patient demographics, mechanism of injury, and clinical variables related to presentation, management, and outcome in a REDCap registry. A total of 128 patients met inclusion criteria, 78% being male. Glass injuries were the most common, followed by firearms and motor vehicle collision. The extremities were the most common site of injury at 84%, followed by truncal and head and neck. 94% of patients with one or more hard signs of vascular injury, which include active or pulsatile hemorrhage, expanded hematoma, absent or diminished pulses, bruised thrills, and diminished or distal signs of ischemia. Almost all patients underwent open repair of their vascular injuries. Endovascular approach was used in only 4% of the cases. 50% were repaired primarily, 28% ligated, and 20% were repaired with vein grafts. At our center, vascular trauma was often managed by pediatric surgeons, with only 5% managed by adult vascular surgery. The use of postoperative anticoagulation varied and included heparin, aspirin, and Lovenox. 17% developed complications, most commonly infection. There were only 5 deaths, most of which were truncal injuries, and only 4 amputations. In conclusion, complications were common. However, there was high limb salvage rates and overall low mortality in children who underwent surgical repair of vascular trauma. In addition, there was significant variability in the workup and management of the pediatric vascular trauma at our high-volume trauma center. Thank you. Any questions?
Thank you. Can you be a little more specific on who repaired these vascular injuries? Because it looks like your slide says that 39% are repaired by pediatric surgeons, and you said only 5% by adult surgeons. So who's doing the majority?
So 39%, the majority is pediatric surgery. We also had a large chunk of plastics and orthopedics doing the repairs as well. Just for the sake of time saving, we didn't include them, but those were the top 3. Vascular trauma, adult surgeons were the lowest with 5%.
Thank you.
Thank you.
Next, we'll be hearing from Dr. Mohammed Sharif on efficacy of intralesional bleomycin alone and in combination with dexamethasone in infantile hemangioma.
Thank you very much for giving me opportunity. My presentation is about efficacy of interlesional bleomycin alone and in combination with dexamethasone in the treatment of infantile hemangioma. Where is the next? So objective was to compare the both treatment alone and in combination with dexamethasone. So this was randomized controlled trial conducted at Department of Pediatric Surgery, King Edward Medical University and New Hospital Lahore, and there were two groups, 57 in each group. In group A, only bleomycin was injected, while in group B, both bleomycin and injection dexamethasone was injected at the interval of 4 weeks. Then we see the results. And the dose was given less in the area of the face and neck, 0.5 milligram per kg and 1 milligram per kg on the other sides. So when we see the results, results were almost comparable regarding reduction in size and flattening of the lesions, and also regarding recurrence. But only the difference was that there was rate of reduction was more in the group where the combination of bleomycin and dexamethasone was given, while in otherwise there was no difference in the results between the two groups. So we conclude that both treatment are effective in the treatment of infantile hemangioma, but the combination treatment has more rate of reduction than the other treatment. Thank you very much. Any question?
Thank you. Thank you.
Thank you. Our next speaker is Dr. Hannah Cockrell on the impact of linguistic minority status and interpreter use on pediatric surgical outcomes.
Thank you. We aim to evaluate the association between linguistic minority status, interpreter use, and pediatric surgical outcomes at a quaternary pediatric surgical care facility with a diverse patient population. We performed a retrospective cohort study of pediatric patients who underwent surgery during a 5-year study period. Outcomes were 30-day postoperative mortality and serious adverse events, which we defined as sepsis, cardiac arrest, unplanned return to the operating room, and unplanned hospital readmission. Logistic regression modeling was used. Patient age, ASA classification, case time, and area deprivation index were adjustment covariates. More than 56,000 patients were included in analysis. 11% had a language other than English documented as their preferred language of care. The incidence of 30-day postoperative mortality and serious adverse events was 0.3% and 8.9%, respectively. Compared to English, all other language groups had increased odds of mortality, with the greatest effect size being for other language speakers, with an adjusted odds ratio of 5.74. Similarly, compared to English, all other language groups experienced increased odds of serious adverse events, although effect sizes were modest and these results did not meet criteria for statistical significance. The average number of interpreted sessions per hospital admission day was 2.4, and we found that interpreter use was associated with a modest decreased odds of serious adverse events, but not for mortality. In conclusion, linguistic minority status was associated with significantly increased odds of postoperative mortality in our patient population. Interpreter use showed a modest protective effect against serious adverse events. And in conclusion, to improve health equity and pediatric surgical outcomes, additional inquiry is needed to understand inequities experienced by patients surrounding preferred language of care. Thank you.
So you have a question from the audience, I believe?
This is really interesting data. I mean, that's a pretty strong effect that you found. But you know, they say that strong claims, extraordinary claims and extraordinary evidence. Is there a linkage between language status and disease process? That is, do patients who don't speak English in Seattle present with a different spectrum of diseases? And it might be a correlation and not a causality?
Right, thank you for that question. We did try to control for comorbidities, but we were limited in our analysis because of small event sizes. So all we were able to control for was ASA classification, and ASA classification was associated with increased odds of postoperative mortality, as you would expect. In order to power the analysis, we included patients who received surgical care across all pediatric subspecialties. So I don't have the CPT code breakdown for what they were undergoing surgical care for and how that varied by language group. So that is a limitation to our data. Thank you.
Thank you.
Next, we'll be hearing from Dr. Peter Juveler on complicated appendicitis readmissions reduced following postoperative guideline and routine intraoperative cultures, longitudinal benefits of quality improvement.
Thank you. Our children's hospital was identified as a NSQIP pediatric high outlier for SSI following appendectomy for complicated appendicitis. In response, we implemented a clinical practice guideline that standardized antibiotics, as well as included routine intraop cultures to guide continued therapy. The intervention reduced complicated appendicitis SSI rate by 55%. We hypothesized that this decrease in SSI would be associated with decreased post-op readmissions and ED visits over time. Intervention began in January 2020 with 1.5 years baseline data and 2.5 years of post-intervention data. This chart represents percentage of readmissions, ED visits, and surgical site infection pre- and post-intervention. In blue, you can see that the post-op readmissions to the pediatric surgical service decreased from 9% pre-intervention to 1.7% post-intervention. In orange, post-op ED visits went from 15 to 5%. And in green, the reduction in SSI was maintained over the study period, 22% pre to 9% post. Our process measure intraoperative fluid culture was obtained for 99% of patients. There were no differences in balancing measures, including median length of stay and C. diff infection. Ultimately, a reduction in SSI was associated with reduced readmissions and ED visits. And please stop by our poster 19 if you'd like to see the G charts with the readmission and ED visit trends. Thank you.
Dave Notriga, Phoenix. What antibiotic were you on before the protocol?
So after the protocol was piperacillin and tazobactam. Before it was a mix of ceftriaxone, flagyl for the complicated, and we switched over based on local susceptibilities. And then with the intraop cultures guide the antibiotic choice when we switch over to oral after. Okay, thanks.
Our next presentation is by Dr. Pooja Salvi, Development and Implementation of an Add-on Case Delay Dashboard for Quality Improvement in a Children's Operating Room.
Good afternoon. Thank you for the invitation to speak. Perioperative delays in children's hospitals are a daily occurrence and have consequences for patient care, healthcare costs, and workplace satisfaction. Analysis of system-wide inefficiencies that lead to perioperative delays often focus on process metrics. We sought to answer the question of whether implicit bias in a hospital system leads to certain groups being more affected by perioperative delays. We looked specifically at key diversity, equity, and inclusion metrics, or DEI metrics, including patient race, insurance status, and surgeon gender. To conduct this analysis, we rolled out a dashboard for perioperative staff to report causes contributing to case delays for non-elective surgery. A representative screenshot of the dashboard is shown here. The dashboard allowed us to retrospectively filter by surgical service and type of surgery, the urgency with which a case was booked, time from case creation or case booking to case start, and self-reported reasons for delays. We analyzed data from more than 3,300 add-on cases at Yale New Haven Children's Hospital between February 2018 and March 2022. As expected, the acuity with which a case was booked strongly predicted the speed with which the case was taken to the operating room. We found no relationship between patient race, insurance status, or surgeon gender and time from case creation to case start. This was true both in univariate analyses, which are shown, as well as multivariate analysis, which took into consideration the acuity of the case, type of surgery, time of day, and day of week. Although this was a negative study and that we found no evidence that perioperative delays carry an undue burden for minorities, uninsured patients, or by surgeon gender, the approach to answering this question is novel. While the findings are unique to our setting, in the manner of quality improvement, we intend to conduct analysis of DEI metrics on an annual basis and believe that this approach is generalizable to other hospital settings and can be adopted as a way of identifying potential modifiable manifestations of inequity in delivering surgical care. Thank you.
Thank you for your presentation.
One question.
There is a question. Sorry.
Oh, sorry. Go ahead.
It's Doug Miniotti from Kaiser Roseville. Thanks for that presentation. This is like the bane of my existence, trying to get into the operating room. And I think it's a great idea that I'm going to take back to my institution to do this kind of dashboard. My question is just to clarify, is your data reporting the delay in expected time to OR or the time to get into the OR from the time of case postings? It looked like your times to get in were actually pretty good. Like your 2-hour level got in 140 minutes. Does that mean that it got in 140 plus 2 hours or in 140 minutes?
So this data was for non-elective add-on cases. So the numbers that you saw were from the time that the case was booked until the time that the case was taken to the operating room, the raw numbers.
I'm jealous.
Our next presentation will be given by Gerard Martusiello, who will be speaking about implementation of standardized caregiver education with photos of expected healing reduces healthcare utilization following Plastibell circumcision.
Thank you. We have no disclosures. So Plastibell circumcisions can cause a high level of caregiver anxiety regarding healing of the circumcision site. We noticed that many caregivers would call the office or send EMR messages including images with concerns about the healing of their child. Our aim was to create and implement a post-Plastibell circumcision caregiver handout that included photos of expected healing and evaluate the post-procedure healthcare utilization and receive caregiver feedback. We evaluated all circumcisions that occurred between April 2021 and March of 2022. You could see the handout on the right side of the screen, and it included pictures from a family that took pictures of the circumcision site over a 2-week period so that we could use in our handout for future patients. We measured healthcare utilization to compare during the 6 months prior to and following implementation. Additionally, we invited caregivers over a 1-month period of circumcisions to interview to discuss their thoughts on the handout and the healing process. Overall, we found that the percentage of caregivers sending EMR messages significantly decreased in the 6 months following handout implementation. We also found that there was significantly less caregivers calling the office, although this was not to statistical significance, likely due to the power of our study, and there was no difference in the number of follow-up visits or complications. There was 13 interviews that were completed, and 12 out of the 13 caregivers interviewed found that the handout was helpful, especially the included images. And in conclusion, education materials following circumcisions provided a simple and effective way to reduce healthcare utilization, and development of similar materials for other surgical procedures should be considered. Thank you. If you could reach out to me, I can give you my email after.
Thank you very much.
Our next presentation is Improving the Pediatric Peri-Procedural Experience, What the Family Wants Us to Know, presented by Maximilian Selbst.
Thank you. So our Peri-Procedural Parent Advisory Council recommended a tool that would allow family input to improve the patient experience and enhance patient safety. Alongside the parents of the Advisory Council, a multidisciplinary team created the Toppers Boarding Pass form, which was given to all parents of patients at our hospital having a procedure requiring anesthesia. The form contains questions about the patient's preferred name, how they wake up from anesthesia, what to do, what not to do for the patient, and even a place to provide extra information. The form traveled with the patient in their physical chart until they were discharged from the recovery room. We then conducted a retrospective review of the forms and a thematic and descriptive analysis of the responses. We received over 1,000 forms. The average age of the patient was close to 7 years old. Slightly more than half were male, and 89% of the responses were in English. A surprising find was that about a quarter of the patients had a preferred nickname completely different from the name reported in their medical record. So we received hundreds of responses, and here are some examples of themes and actual responses from the Please Don't prompt. So close to half of the responses included the environment, such as the noise or lights level. About 30% involved medical information, such as triggers of vertigo. And nearly 10% involved specific fears or dislikes, like this patient who doesn't like being touched or talking about blood. Another very informative prompt was the It May Help You to Know section. Most of the responses contained medical information, such as unusual reactions to medications, and nearly 20% of the responses were related to pain control. So parents provide essential information that may not necessarily be in the medical record, and providers need to ask and listen, thereby empowering the patients and their parents. And not only did the parents appreciate having a voice for their child, but the staff also found it very informative and helpful. Our future plan is to survey the parents for any improvements, as well as expand the form to inpatients and adults. Thank you, and are there any questions?
I think we have a question from the audience.
Thank you, Sharif Emil, Montreal. Beautiful work. I mean, it just boggles my mind that we've gone so long without actually getting this kind of information. This is a really large group. I just wanted a clarification on this medical information. I wasn't so clear. So giving medical information without sedation induced vertigo? I didn't catch that.
So in some of the responses, we got some specific indications or ways that child would have a spout of vertigo that may not necessarily be readily accessible in the medical record, just things that parents wanted to quickly notify the caregivers of.
Okay.
Yeah, thank you for your question.
Thank you very much.
Thank you.
Our next presentation will be given by Dr. Ray Hankey on car seat airbag, a concept designed to decrease injuries in horse-drawn buggy accidents.
Thank you for the opportunity to present today, and we have no disclosures. So in central Pennsylvania, we have a large Amish population who heavily rely on horse-drawn buggy transport. And these buggies are not designed with safety standards of our modern vehicles and are actually designed to shatter on impact. So depending on the institutional study, they've shown that buggy-related trauma is actually the second or third most common cause for traumatic injuries in Amish children. So we met with members of the Amish community to address this issue and noted that infants are particularly reliant on car seats for their safety, but unfortunately, the car seat is not actually secured in the buggy very well. It is often catapulted from the vehicle on impact. And as the child's head is the heaviest part, they often rotate and land head first with resulting injuries. So then we met with engineering students from State College to design a potential solution for this. And our initial inspiration was actually from Baby Yoda as a potential idea of where to launch from. So we ultimately considered 5 prototype ideas. The first was a bodysuit. The second was a Yoda ball. The third, a neck pillow that deployed into a helmet along the head and along the chest. Or a completely new seat design that ejected upon impact with surrounding airbags, which is quite costly. And finally, the idea of an airbag addition to car seats that are already being used in the community that would be housed in the handle of the car seat. So we ranked these possibilities based on different criteria, including head protection and deployability. But most importantly, we needed to consider cultural sensitivity, as the Amish community limit electronics and need a compact, portable, low cost, and low maintenance solution. So the airbag car seat addition scored highest, and so we moved forward with that possibility. The final design that we were able to come up with used established airbag technology actually from a horseback riding vest with a new trigger mechanism that we were able to put on the handle of the car seat. And as you can see here, it would actually protect the head and then part of the body, unfortunately not the entirety of the body, but definitely an improvement. So while this is designed initially with our Amish population in mind, this could be applied broadly to non-traditional modes of transportation used around the world. And our next steps are to optimize that trigger mechanism that was designed, explore the feasibility of manufacturing this solution, and then talk about the ultimate certification through the National Child Passenger Safety Board, which is a whole another feat. And I'm happy to take any questions.
I don't have a question, but a comment that this is just an ingenious use of great collaboration with other specialists in answering a complicated problem for a specific community, but that does have implications, I think, in a lot of other communities as well. So great work.
Thank you.
Our next presentation will be given by Dr. Allison Mack on postoperative hydration with intermittent boluses of balanced salt solution is safe and effective. Preliminary results of the BRISC randomized control trial.
Thank you. So standard procedure at our hospital is the provision of continuous intravenous fluids at a maintenance rate, particularly after major abdominal or thoracic surgery when children are not as able to maintain adequate oral intake. When patients are on continuous infusions, the nurses need to check their IV sites hourly, and they also remain tethered to IV poles. This can be disruptive to sleep and to healing. We hypothesized that hydration with scheduled weight-based boluses of balanced fluids, such as lactated ringers, may be more physiologic and could even improve patient mobility and comfort. We performed a pilot randomized control trial to compare boluses of balanced salt solution to standard continuous fluids in postoperative pediatric patients. We enrolled patients from February through September of 2022. Eligible patients were those aged 1 to 21 years who were admitted to the surgical ward following abdominal or thoracic surgery. Patients that were admitted to the intensive care unit were excluded, as were any patients with known renal or metabolic disorders or those on parenteral nutrition. Patients were randomized to receive either standard continuous fluids or intermittent boluses of lactated ringers. We measured urine output, serum glucose, electrolytes, and urine-specific gravity. We enrolled a total of 60 patients, 31 to the treatment arm or the bolus, and then 29 to continuous or standard arm. The mean age of our patient cohort was 12.4 years with a range of 1 to 19 years. There were no serious adverse events in either arm, and there were no significant differences between urine output or laboratory values. Based on the preliminary results of our randomized controlled trial, we saw that a regimen that includes boluses of balanced salt solution could be safe and effective in hydration of healthy children who undergo abdominal or thoracic surgery. Thank you.
Was there any difference in the types of operations that these kids had between the two groups?
The operations were the same, so we included all abdominal and thoracic, so laparoscopic, thoracoscopic, open, so no significant difference in the types of surgery, patient ages, or operative length. Thank you.
Thank you. Our next presentation is by Dr. Michelle Saruatari on electroadhesion of hydrogel patches, a novel and sutureless alternative for intestinal repair.
Thank you. I'll be presenting this work from a collaborative team from the Children's National Hospital Sheikh Zayed Institute for Pediatric Surgical Innovation and the University of Maryland Department of Bioengineering. We have no financial disclosures. Electroadhesion is the strong adhesion that can be induced between positively and negatively charged materials through the application of a low-voltage electric field. In this video, oppositely charged gels are electrically adhered using this technique. After the electric field is applied, the gels become strongly attached, as you can see here, while in the control gels, no adhesion is observed and the gels detach easily. In this study, we investigated electroadhesion of hydrogel patches and as a management strategy for intestinal perforation. Utilizing a mouse model and manipulating the fact that animal tissues are inherently negatively charged, a positively charged gel was used in this preliminary model. First, a full-thickness intestinal injury was created, followed by application of a QDM gel patch. An electric field of 9 volts was applied for 30 seconds, and strong adhesion of the gel and intestine was confirmed. A control group was treated with interrupted suture repair. A total of 3 groups were assessed. Group 1 was treated with suture repair, Group 2 with electroadhesion, and Group 3 with gel applied topically without electric field application. All animals were evaluated on postoperative day 6. Our primary goal was to assess whether electroadhered gels could effectively adhere to injured intestine and prevent leakage of enteric contents for a durable period of time. In our model, all treated with suture repair and electroadhesion survived to the experimental endpoint. However, 75% of animals treated with topical gel application without electric field application died on postoperative day 1 due to gel detachment. All electrically adhered patches remained attached to the intestine on day 6. We also scored abdominal adhesion severity using the scale shown here. In animals with intestinal perforation, suture repair resulted in more severe adhesive disease than repair with electroadhesion. In conclusion, our model demonstrated that electroadhered gels effectively adhered to injured intestine and prevented leakage of enteric contents for at least 6 days with equivalent healing outcomes, without adversely impacting procedural time or mortality, and with a possible benefit for post-surgical abdominal adhesion formation. Electroadhesion is also effective in adhering gels to multiple other tissues throughout the body, and we are continuing to investigate this technique as a surgical tool. Thank you.
Thank you very much for that presentation.
Yeah, it's fascinating application of technology, Andrew, from Children's Colorado. Quick question, as you look toward bringing this through the FDA, what is the material made of in the gel?
It's a quaternized dimethyl aminoethyl methacrylate, so it's a methacrylate-based gel. We've done preliminary cytotoxicity studies, and it's not cytotoxic. However, it does not biodegrade very rapidly. This was more of a proof of concept study, and we're actively working with our bioengineering colleagues to come up with various positively charged gel formulations for this application.
Very cool. Thank you.
Thank you.
Our next presenter will be Dr. Walker Short, speaking about trends and satisfaction of telemedicine utilization for pediatric surgical clinical visits throughout the COVID-19 pandemic.
Thank you. It's great to be here to share this data with you all. We have no disclosures. So the COVID-19 pandemic spurred a rapid and necessary transition to telehealth, which became more convenient for, I think, providers and patients. A recent survey of APSA members demonstrated that a lot of surgeons really do think that this is a methodology that's going to be here to stay. And their belief was that patients actually have improved satisfaction. However, there have been limited large studies that objectively measure patient satisfaction. So the aim of our work was to gather and extract what percentage of our patients are undergoing telehealth and see the trends of telehealth utilization since the COVID pandemic started, as well as assess the patient satisfaction objectively using Press Ganey data. So this was data was extracted from 2019 to 2022. We looked at the numbers of patients that were seen by various surgical subspecialties, and then for the 2021 year, we used Press Ganey, stratified the responses into satisfied and not satisfied, as you can see here. So in about a 2.5-year period, we had a total of 265,000 clinic visits across our surgical specialties. Around 9% of 24,000 of these were telemedicine. On the chart on the screen right, you can see the average over this time period of utilization, with most utilization done by neurosurgery, urology, and pediatric surgery, with more procedural clinic specialties had a much lower percentage. If we zoom into the time period that occurred after the implementation and availability of the vaccine, so starting in January 2021, we can see that utilization does trend down over time. In fact, it's over this time period of about a year, it decreases by about half. Our Press Ganey results were also from 2021 that we compared to in-person and telehealth data, showed that actually there was no decrease in satisfaction. A majority actually had an increase in satisfaction in their care, most surprisingly in patient inclusivity and decision-making, which I thought was very interesting. So in conclusion, despite Press Ganey data supporting strong patient satisfaction, we've seen a decline in the use of telemedicine. I think this implies that we need more study and more advocacy if we wish to keep this an option for treating patients. Be happy to hear any comments or questions.
Thank you. In the interest of time, we'll keep moving on. The next presentation is by Dr. Nicole Becker, Novel Securement Method for External Tunneled Central Venous Access Devices.
Hi, my name is Nicole Becker. Thank you so much for the opportunity to speak today. Tunneled central lines are a universally used, very common tool for the administration of essential medications and fluids for patients across all ages with acute and chronic illnesses. Unfortunately, these devices are highly susceptible to complications such as fracture, dislodgement, and infection. 25% of these catheters can fail prior to completion of treatment. Current methods help to address the infection risk, but there's nothing really in place that helps to address the risk of premature dislodgement or fracture. As such, this provided an opportunity for innovation. In 2019, a pediatric surgeon and a group of graduate engineering students came together to try to address this universal problem. After multiple iterations of designs, the first generation prototype on your left was developed. It features a unique wrapping post that helps to distribute the tensile forces applied to the catheter when tugged, as well as a lid with a living hinge and a clip on the side for the venous port. After some feedback, in an attempt to obviate the choking hazard as well as to prevent any pinching of the catheter, the second generation prototype on the right was developed. It features a polymeric flexible lid, a unique D-shaped wrapping post, and continues to have the clip for the venous port on the side. And then on the right, you can see how it would work with the existing standard of care dressings. The next steps in this project are to perform a randomized controlled clinical trial comparing the use of standard of care sterile dressings, as are currently in hospital protocol, to the addition of our novel securement device. Thank you, and I'll take any questions.
Does your device lead to decreased need for dressing changes, or it doesn't impact that?
It doesn't impact because, as you can see kind of on the rightmost image there, it will be below the exit site. It'll be about an inch below the exit site, so dressing changes can occur as normal in accordance with hospital protocol without interference.
Thank you.
Thank you.
Is our next presenter Dr. Carter in the audience? Yep, she is. Okay, great. So our next presenter would be Dr. Michelle Carter, who will be speaking on utility of a white light scan index as an alternative to the Haller index in determining need for surgical correction of pectus excavatum.
It's Michaela, but don't.
I'm so sorry about that.
Severity of pectus excavatum and ultimately surgical candidacy is determined by the Haller index as measured on CT scan. White light scanning has been proposed as a non-ionizing alternative. Therefore, the objective of our study was to determine if we could create a predictive model that is able to use just white light scan alone to determine surgical candidacy. Children less than or equal to 18 years old who came to a high-volume chest wall clinic between 2015 and 2022 were included in our study. All had a CT scan and white light scan performed within 1 year of each other. Using the white light scan, we were able to measure the anterior-posterior, medial-lateral, and corrected anterior-posterior dimensions. Using these values, we then were able to calculate the white light scan equivalent for Haller index and correction index. We then performed a linear discriminant analysis, where we used these 5 white light scan measurements as a predictor variables and able to predict if a patient's CT Haller index was greater than or equal to 3.25. 234 patients were included in our study that had a median age of 15.2 and Haller index of 4.3. Evaluating the model's performance, the accuracy was 90%, sensitivity 58%, and specificity 97%. So in conclusion, for patients who are thought to be surgical candidates for surgical correction of pectus excavatum, we feel that white light scan should be the first imaging modality that is acquired. If they are predicted to have a Haller index that is greater than or equal to 3.25, we feel it is safe based on the specificity to proceed with surgical correction. However, if they are predicted to have a Haller index that is less than 3.25, they should then undergo CT scan in order to determine their surgical candidacy. I'm happy to take any questions.
So have you been able to convince insurance companies to accept that as a model as well, or where do you stand with that?
You hit the nail on the head. So we have to publish the data that it is equivalent to the Haller index, or hopefully better than the Haller index on CT scan. And then insurance companies will hopefully reimburse based on the white light scan.
Romy Ignacio, San Diego. Nice presentation. How does it work for like obese patients or female patients with pectus excavatum?
That's also a very great question. Because these measurements on white light scan are an external index, because it only scans the outside of the patient, versus the Haller index or correction index, which is the internal thoracic measurements. There is some difference when patients are larger. However, in our patient cohort, the BMI is a mean of 18. So all of these patients are quite thin by nature.
Thank you very much.
Thank you.
Our next presentation is by Dr. Takanori Ochi, Comprehensive Analysis of Gut Microbiota in Postoperative Biliary Atresia Patients, Native Liver versus Transplanted Liver. Thank you.
Thank you. Bacterial translocation and gut microbiota derived metabolites may be implicated in the pathogenesis of liver disease through a host microbiome-derived syndrome. As all biliary atresia patients require surgical intervention to survive, differences in gut microbiota were compared between native liver survivors after potentiotomy or liver transplant survivors after FLPE, and age-matched healthy control. Subjects were native liver survivors, inserted 1, liver transplant survivors, inserted 1, and controls, inserted. Patient demographics are shown. All subjects were clinically stable throughout the study period, with no dietary restriction and no antibiotics. LTX subjects were immunosuppressed. Results: total bacterial count and predominant obligate enrolled were both significantly decreased in native livers and liver transplant survivors. An abundance of potential pathogens such as C. difficile, Enterobacteriaceae, and Enterococcus were present in native liver and transplanted survivors. Notably, Enterobacteriaceae and Enterococcus were more abundant in liver transplant survivors compared with native liver survivors. In conclusions, this biosis was observed in both native liver survivors and liver transplant survivors, but it was worse at liver transplant survivors. It was an unexpected finding because liver transplant survivors, normal serum biochemical marker was observed. This discrepancy may be related to immunosuppression. This study insight into the effect of surgical intervention and the impact of immunosuppression on gut microbiome in post-operative BA patients. Thank you for your attention.
Have you done any studies to see if this dysbiosis has an impact on their outcomes?
Actually, there are no, all the patients are clinically stable. So actually, the differences was observed, but no phenotype was not detected.
Thank you.
Thank you very much.
Thank you.
Our next presenter is Dr. Hester Shea, who will be speaking on tracheobronchopexy to avoid tracheostomy in esophageal atresia patients with severe life-threatening tracheobronchial malacia.
All right, thank you. Esophageal atresia is associated with tracheobronchial malacia, which in its most severe form causes blue spells, bruits or altes that can require CPR, and positive pressure or ventilator dependence. Tracheostomy is initially recommended for most. However, tracheostomy is not an ideal treatment for TBM as shown here. We study the role of tracheobronchopexy as an alternative to tracheostomy in EA patients with severe life-threatening TBM. These techniques include posterior tracheopexy, which fixes the posterior tracheal membrane to the anterior longitudinal ligament of the spine, or anterior tracheopexy, which fixes the anterior wall of the trachea to the sternum with bovine pericardial struts. These are all done under direct bronchoscopic guidance. We retrospectively reviewed all EA patients who underwent tracheobronchopexy for severe TBM symptoms at 2 institutions. 80 EA patients, mostly type C, underwent 91 tracheobronchopexies at median age 6 months. On preoperative dynamic bronchoscopy, most demonstrated complete airway collapse. Surgical approach for tracheobronchopexy was mostly posterior. At median follow-up of 22 months, there were no recurrent blue spells or bruits, and significantly reduced positive pressure and ventilator dependence. Nearly all patients avoided tracheostomy. Mortality was 4%, 1 30-day operative mortality, and 3 long-term mortalities related to underlying comorbidities. In conclusion, in EA patients with severe life-threatening TBM, tracheobronchopexy significantly reduces blue spells, bruits, positive pressure, and ventilator dependence, and avoids tracheostomy. This surgical strategy should be considered the treatment of choice for EA patients with severe life-threatening TBM symptoms. Thank you.
I had a question. The results you showed were really, really excellent, in my opinion. I'm curious, after patients have been pexied, how do you recommend they be followed? Do you recommend routine surveillance bronchoscopy, or really just only, surveilling them if they develop recurrent symptoms?
Yeah, I think in this particular patient population, which is all EA patients, we generally recommend surveillance bronchoscopy in coordination with their EGDs.
Thank you very much.
Thank you.
Our last presenter of the session is Dr. Ayman Al-Jazari on enhanced fluid drainage using a novel multipod drainage catheter in vitro evaluation.
Thank you. As you know, catheter clogging is one of the most common problems facing drainage catheter across different specialty, particularly long-term catheter that are implanted. To solve this problem, we came up with a novel design, a main catheter that houses multiple smaller catheters that can be deployed remotely once the catheter is placed in the desired cavity. The concept focuses on the ability to expand the surface area and therefore increase the number of draining pores, as well as the ability for the smaller catheter to drain different location when placed in the desired cavity. To prove the concept, we came up with an experimental model. To simulate clogging medium, we added sodium polyacrylate granules that expand when hydrated and transform to gel. And we added also cotton fiber to simulate tissue clogging. We compared this to water only. And we compared 3 types of catheter: the multi-pod catheter, a size-matched closed-tip catheter, and an open-tip catheter. You can see the results here. The white chalk boxes represent the placing the catheter in non-clogging medium of water. They all drain the first 200 ml within less than a minute. However, when we place the catheter in a clogging medium, the open-tip catheter stopped draining after 95 ml. The long-term, the closed-tip catheter drained the first 200 ml within 9.5 minutes. And our catheter drained the first 200 ml within 1.5 minutes. In conclusion, we think the novel design can enhance draining and resist clogging. And further experiment will require a living model to prove the concept. Thank you.
Great job. I wanted to ask, some of the catheters that we put in children are known to clog when you apply suction to them, like the peritoneal dialysis catheter, or at least every peritoneal dialysis catheter that I place. Have you tried your device with applying suction to it and seeing if that changes any of the results?
The main focus here is the peritoneal dialysis catheter. We think whether suction or without suction, the main problem is the limited surface area. So when we expand the surface area and number of pores, the likelihood by chance to have a clog is diminished. Thank you.
Good job. Thank you.
Thank you very much. Thank you, everyone, for your great attention for this quick shot session. We look forward to welcoming you all at the welcome reception on the portico at 7 p.m.